Decoding your blood work. What optimal vitamin D levels really mean. Your doctor looks at your vitamin D result. It says 32 nanograms per milliliter. They tell you, you're fine. Normal range. Nothing to worry about. But here's what they didn't tell you. That normal range was designed to prevent rickets and osteomalacia, deficiency diseases from the 1930s. It was never designed to define peak immune function, optimal brain health, or long-term metabolic resilience. You can be clinically sufficient and biologically starved at the same time. Today, we're going past the lab reference range. We're decoding what your vitamin D number actually means at the cellular level, how it's made, what stops it from working even when your serum level looks fine, and why your genetics and magnesium status may matter more than the number on your report. This is the science your blood work doesn't explain. Let's start with a fundamental question. Where does the normal range for vitamin D come from? Most laboratories flag vitamin D deficiency below 20 nanograms per milliliter, 50 nmol, and mark anything above that as sufficient. Some extend the range to 30 nanograms per milliliter. But here's the scientific problem with that. Standard reference ranges in laboratory medicine are typically derived from the central 95th percentile of a tested population, not from clinical outcomes research. In populations where widespread vitamin D deficiency is common, which describes most of the industrialized world, that range is built on a baseline that is itself depleted. The Institute of Medicine, IOM, set 20 nanograms per milliliter as the cutoff based primarily on bone health endpoints, specifically, fracture prevention and calcium absorption. That is a narrow, skeletal-focused metric. The Endocrine Society, by contrast, recommends levels above 30 nanograms per milliliter for general sufficiency, and acknowledges that levels between 40 to 60 nanograms per milliliter may be optimal for extraskeletal functions, including immune regulation, cardiovascular health, and cancer prevention. A landmark 2011 paper published in the Journal of Clinical Endocrinology and Metabolism by Hollick et al. Formally articulated this gap, distinguishing between levels sufficient to prevent bone disease and levels associated with optimal non-skeletal biological function. The peer-reviewed evidence clustering around 40 to 60 nanograms per milliliter for optimal function is substantial. But most laboratory reports still flag anything above 20 as normal, leaving a wide biological gap unmarked and unexplained. To understand why your serum level can be misleading, you first need to understand the full conversion pathway, because what your blood test measures is not the active form of vitamin D. Here's the complete journey. Step 1. Skin synthesis. When UVB radiation, specifically wavelengths between 290 to 315 nanometers, strikes your skin, it converts a cholesterol precursor called 7-dehydrocholesterol into pre-vitamin D3. Heat from the skin then isomerizes it into vitamin D3, also known as cholecalciferol. This is the form also found in fatty fish and some fortified foods. It is biologically inert at this stage. Step 2. Hepatic hydroxylation. Vitamin D3 travels to the liver, where the enzyme CYP2R1, and to a lesser extent 27 cypriot pounds A1, adds a hydroxyl group, converting it to 25-hydroxyvitamin D, written as 25-O-D, also called calcidiol. This is what your standard blood test measures. It's the storage and transport form. Still not biologically active. Step 3. Renal activation. 25-O-D travels to the kidneys, where the enzyme 27 billion cypriot pounds 1, also called 1-alpha hydroxylase, performs a second hydroxylation, producing 1,25-dihydroxyvitamin D, written as 1,25-O-2D, also called calcitriol. Calcitriol is the biologically active hormone. It binds to the vitamin D receptor, VDR, inside cells and directly regulates gene expression. Here is the critical insight. Your blood test measures 25-O-D, the storage form. It does not tell you how efficiently your body converts it to calcitriol, how well your VDR responds to it, or whether downstream gene activation is actually occurring. A serum level of 40 nanograms per milliliter in one person may translate into dramatically different cellular activity than 40 nanograms per milliliter in another, because the conversion pathway has multiple vulnerability points. This is the part of vitamin D biology that is almost universally overlooked, in clinical practice, in patient education, and in standard blood panels. Both conversion steps, the hepatic CYP2R1 step and the renal 27 billion cypriot pounds 1 step, are magnesium-dependent enzymatic reactions. The enzymes cannot function without adequate magnesium as a cofactor. A landmark 2018 study published in the American Journal of Clinical Nutrition by Deng et al. Demonstrated that magnesium status directly modulates the metabolism of vitamin D in populations with low magnesium intake. Vitamin D supplementation was significantly less effective at raising active calcitriol levels, even when serum 25-OD rose appropriately. This creates a specific and clinically important scenario. A patient takes vitamin D supplements. Their serum 25-OD rises to 45 nanograms per milliliter, well into the optimal range. Their doctor is satisfied, but if their magnesium status is depleted, and approximately 48% of Americans consume less than the recommended daily magnesium intake, according to NHANES data, the enzymatic conversion to calcitriol is impaired. Their cells are not receiving the active hormone their blood test implies they should be getting. They remain functionally deficient at the cellular level while appearing sufficient on paper. Additionally, calcitriol itself increases renal magnesium reabsorption, meaning the relationship is bidirectional. Low magnesium impairs vitamin D activation, and low vitamin D impairs magnesium retention. They deplete each other in a self-reinforcing cycle. The clinical implication is direct. Vitamin D sufficiency cannot be fully evaluated without also assessing magnesium status. And yet magnesium is almost never included in standard metabolic panels. Even if your synthesis pathway is intact and your magnesium is adequate, there is another layer of variability that your serum test cannot capture: genetic polymorphisms in the vitamin D receptor and metabolic enzymes. The vitamin D receptor gene, VDR, contains several well-characterized single nucleotide polymorphisms, SNPs, that alter receptor function and therefore cellular response to calcitriol, regardless of how much is circulating. The four most studied VDR polymorphisms are FOCI, 2,228,570 rupees, affects the length and transcriptional efficiency of the VDR protein. The FF genotype produces a slightly longer, less efficient receptor, meaning the same calcitriol level activates fewer target genes compared to the FF genotype. BSMI, 1,544,410 rupees, API, 7,975,232 rupees, and TAKI, 731,236 rupees. These three are in linkage disequilibrium. They tend to be inherited together, and collectively influence VDR mRNA stability and expression levels. The BB haplotype has been consistently associated in meta-analyses with lower bone mineral density and altered immune responses. A 2014 meta-analysis in Molecular Biology reports found that VDR polymorphisms, particularly BSMI and FOCI, are significantly associated with susceptibility to autoimmune conditions, infectious disease vulnerability, and cancer risk, independent of circulating vitamin D levels. Beyond the VDR, polymorphisms in 2-cypriot-pounds-R1, the hepatic hydroxylase, directly impair the liver's ability to convert D3 to 25-OD. Individuals with reduced function CYP2R1 variants may require substantially higher intake to achieve the same serum level as someone with wild-type enzyme function. And 24-cypriot-pounds-A1, the enzyme responsible for degrading calcitriol, also shows polymorphic variation. Loss of function CYP24A1 mutations lead to elevated calcitriol, while gain-of-function variants accelerate its breakdown, reducing cellular exposure even at adequate serum levels. The practical implication: two people with identical 25-OD readings can have profoundly different biological vitamin D status depending on their VDR genotype, CYP2R1 efficiency, and CYP24A1 activity. A blood test alone cannot capture this complexity. So what does the peer-reviewed evidence actually say about where vitamin D levels should be for non-skeletal biological optimization? Immune function. A 2017 meta-analysis in the BMJ by Martineau et al., analyzing 25 randomized controlled trials and over 11,000 participants, found that vitamin D supplementation reduced the risk of acute respiratory tract infections, with the strongest protective effect in individuals with baseline levels below 25 nanograms per milliliter, and meaningful benefit maintained up to approximately 40 to 50 nanograms per milliliter. Cancer prevention. The VITAL trial, a landmark randomized controlled trial published in the New England Journal of Medicine in 2019, found that vitamin D3 supplementation at 2,000 IU per day reduced cancer mortality by 25% over 5 years, with post-hoc analysis suggesting greater benefit in those maintaining levels above 40 nanograms per milliliter. Cardiovascular health. A 2019 Mendelian randomization study in the European Heart Journal found that genetically predicted vitamin D deficiency was causally associated with increased cardiovascular disease risk, with risk reduction plateauing around 40 nanograms per milliliter serum levels. Cognitive function. A 2014 study in neurology found that individuals with 25-OD levels below 25 nanograms per milliliter had nearly double the risk of developing dementia compared to those above 50 nanograms per milliliter, suggesting a meaningful dose-response relationship well above the clinical sufficiency threshold. Across these disease domains, the evidence consistently points toward a functional optimal range of 40 to 60 nanograms per milliliter, with 50 nanograms per milliliter emerging as a well-supported target in multiple research frameworks. This is meaningfully higher than the standard laboratory normal of 20 to 30 nanograms per milliliter. So how do you translate this science into practical action? Step 1. Test correctly. Request a 25-hydroxyvitamin D, 25-OD, test, not 1-25-O2D, which reflects active hormone but fluctuates widely and is tightly regulated regardless of stores. Ask for it to be measured in nanogram per milliliter, and benchmark against the 40 to 60 nanograms per milliliter optimal range, not just the laboratory's flagged threshold. Also request a red blood cell, RBC, magnesium test, not serum magnesium, which reflects only 1% of total body magnesium and remains normal until deficiency is severe. RBC magnesium gives a more accurate picture of intracellular status. Step 2. Address magnesium first. Before or alongside vitamin D supplementation, ensure adequate magnesium intake, 320 to 420 mg daily from dietary sources, dark leafy greens, nuts, seeds, legumes, or supplementation. Magnesium glycinate or malate have the best absorption and gastrointestinal tolerability. Step 3. Supplement D3, not D2. Vitamin D3, cholecalciferol, raises and sustains 25-OD levels approximately 87% more effectively than D2, ergocalciferol, according to a 2011 study in the American Journal of Clinical Nutrition. Always choose D3. Step 4. Pair with vitamin K2. Calcitriol increases calcium absorption, and K2, specifically MK7, directs that calcium into bone rather than soft tissue and arterial walls. D3 and K2 are biologically complementary. Supplementing one without the other at higher doses may carry cardiovascular risk over time. Step 5. Consider genetic context. If you supplement consistently, maintain a healthy lifestyle, and still struggle to raise levels, or if you have a personal or family history of autoimmune disease, chronic infections, or metabolic conditions, genetic testing for VDR and CYP2R1 polymorphisms through platforms like 23andMe or clinical nutrigenomic panels is a legitimate next step. It contextualizes why your serum level may not reflect your biological reality. Your vitamin D blood test gives you one number. What it doesn't tell you is whether that number is being converted efficiently, whether your receptors are responding to it, or whether your magnesium status is allowing the pathway to function at all. Clinical sufficiency and biological optimization are not the same thing. The science is clear. A serum level of 40 to 60 nanograms per milliliter, supported by adequate magnesium, paired with K2, and understood in the context of your genetic variants, that is what true vitamin D optimization looks like. Don't settle for normal. Understand what optimal actually means. If this gave you a deeper framework for reading your own biology, subscribe. This is what we do every week, peer-reviewed science translated into real understanding. See you in the next one. Thank you for watching.